SolRx Incorporation and its review programs are neither related or endorsed by Pharmacy Examination Board of Canada, which is also known as a PEBC. SolRx Incorporation does not provide any certifications. PEBC is a trademark of Pharmacy Examining Board of Canada and is not related to SolRx Incorporation.
So today we'll be talking about my favorite topic, which is smoking cessation. As we know, pharmacists can prescribe for smoking cessation, and we know that on your exams, they tend to touch on trends. So we need to make sure we solidify this topic. Okay, so let's get going. So we know that tobacco use, smoking, whether it's cigarettes or vaping, whatever it is, causes lung cancer, can cause death. And the important thing here is that it can cause death or sickness that is preventable. Remember, as pharmacists, we're always focused on curing, right? Curing disease. And okay, what antibiotic do we use to treat this? What can we use to treat that? But what about prevention, right? Preventing these things from happening, preventing negative outcomes. So as pharmacists, because we can prescribe, and even if pharmacists cannot prescribe, they can recommend treatment that can prevent cardiac disease. Okay, so as we know, other than cardiac disease, smoking can cause reactive airway disease like COPD. What else can it cause? What else can smoking cause? You guys tell me, what can it cause? What are the issues associated with smoking? Dyslipidemia, yeah, high cholesterol, exactly. Very, very good. Stroke, so many issues. And then when you think about it, right? If lung cancer, if somebody is admitted to hospital, okay, for a stroke or heart attack, that is an increased burden on the healthcare system. So not just a burden on the patient, but also a burden on the healthcare system as well. Gastrointestinal disease, exactly. Very, very good. And another problem in terms of the drug interaction perspective is our favorite cytochrome P450 enzymes. Remember, smoking is an inducer of cytochrome P450, mainly 1A2. So is it and you guys tell me, do you remember, is it the nicotine that induces the 1A2 enzyme? What causes the induction of the cytochrome P450 1A2 drug interaction with smoking? And if you don't know, just say, Farah, I don't know. I'm just wanting to. So smoke, yes, exactly. Very good. So dear students, it's the smoke, okay? It's the smoke. It's not the nicotine, and this is very important. It's not the nicotine itself, it's the smoke. The smoke induces cytochrome P450 1A2, which can affect the level of certain drugs, very good, like clozapine and olanzapine in the body. So some patients will say, okay, well, Farah, smoking can affect my clozapine or olanzapine treatment. If I use nicotine replacement therapy, is there going to be an issue? No, because nicotine is not the drug interaction issue. Does that make sense? Does that make sense in this case? What I'm saying? Are you sure? Is anybody a little confused? Okay, so you guys are okay. So let's talk a bit about a hypothetical situation. Let's say you have a patient who is using clozapine, okay? Clozapine is broken down by 1A2. And let's say they are a smoker. They smoke 10 cigarettes a day, 20 cigarettes a day. And then suddenly now they want to reduce the number of cigarettes that they smoke. So let's say they go on smoking cessation treatment with you and reduce the cigarettes they smoke. What's going to happen to the clozapine in the body? What's going to happen if we know that the cigarettes smoke triggers the induction of the enzyme? Let's say they don't decrease the clozapine. Let's say they just stop smoking. What's going to happen? Okay, so I'm seeing some great comments. Accumulation of clozapine increased, reduce. So we're saying to reduce the dose of clozapine, otherwise there will be side effects. So we're saying very good. The level of clozapine will go up. Very, very good. So clozapine will go up because the smoke was breaking it down, breaking it down. So the patient needed a lot. And now suddenly they're smoking less. So the clozapine levels will go up and risk of side effects will go up. Very good. So that's something you have to keep in mind. Great, great, great. I thought I would bring that up quickly here. Very, very good. And thank you for participating. Okay, now let's move on to the next concept, which is goals of therapy. For your exam, for each topic, you have to know the goals of therapy. You don't have to memorize line by line. You don't have to say, okay, main goal, secondary goal, but you have to say, what am I looking to achieve for this patient? What am I targeting? Is it blood levels? What am I targeting in this case? The high levels of clozapine, can it cause seizures? Significantly high levels can increase the risk of seizures. And a good question, going back to the goals of therapy. So in every condition, you have to ask yourself, what am I looking to achieve? So in this case, we want to help the patient quit smoking, but you have to know that it's not usually a one-time treatment. Most of the time, patients will require multiple reattempts. So they may try for 2 weeks and then they may have trouble continuing. Change is very hard to sustain. We have a cycle of change where people are resistant, they don't want to change. Then we can finally convince them, okay, maybe they're willing to change. And then later on, they may potentially have the courage to change. So we have to be able to figure out where are they in this process. And so exactly, and withdrawals can also happen, which will cause patients to want to start smoking again. When you are answering questions related to lifestyle changes, whether it's weight loss, smoking, compliance of treatment, you have to see what the patient prefers. So patient preference is extremely, extremely important. So patient preference is number one. If you give the patient the best drug based on the evidence and they don't take it, that's failure of treatment. So if a patient says, you know what, I want nicotine replacement therapy. I don't want bupropion because bupropion, I heard, can cause really bad nausea. But then you're trying to convince the patient that you think bupropion is better. And if you force them on it, they go home, they likely will throw it in the garbage and they won't use it. So what's the point? So be mindful of when you're looking at goals of therapy and generally assessing the patient, always look at ensuring you are accommodating patient preference to help them quit smoking, because we want this to be lifelong and we have to accept that it may take multiple tries. If you go to a patient and you guys tell me, if I come to you and I say soda is bad for you, okay? So ice cream is bad for you. Ice cream can cause diabetes. Would you stop eating ice cream for the rest of your life? If I told you ice cream can cause diabetes, you may get your leg may get chopped off from amputation. Will you stop eating ice cream for life? Like, well, how would you feel if I told you that? No, you won't listen to me, right? You're not going to listen to me. You're going to say, Farah, I know that ice cream can cause diabetes. I know that, but I'm not going to stop. Same thing with smoking cigarettes. If you go to a patient and say, and I see this all the time, smoking, yeah, it's yummy, right? Smoking can cause cancer. Smoking can cause a heart attack. Patients are going to look at you and say, you think I don't know. See what I mean? So even when you're dealing with patients, you have to find personal motivators. What is important to the patient? Classic one that you guys may have heard me talk about is I had an elderly patient who was a smoker who would smoke in his house. And the motivator to force him to quit after 30, 40, 50 years was he was going to be bringing his granddaughter home after school and watching her. And so he's like, for her, I want to quit. It wasn't necessarily for himself. So anyways, what I'm trying to show you in this goals of therapy and picking treatment is the importance of looking at patient factors and not getting hung up on the right drug. The drug is part of it, but it's not everything. Does that make sense? Are you guys with me? And that'll affect when you're looking at 4 options and they all look the same. This is how you'll be able to pick the right one, right? One of the tips. Yes, no, maybe so. I'm going to wait till you guys answer. So, yeah, okay. Makes sense. Okay, you guys all have to participate. Okay, very good. Yay. Okay, awesome. Now, let's move on to investigations. There's so many ways we can assess the patient, and you don't have to memorize all of them. There's a few things I want you to memorize. First is the 5 A's. That is one of the most important things, not even just for smoking cessation. And we'll talk more about this in the class, but not just for smoking cessation, but in any situation where you want to cause change, whether it's for losing weight, whether it's for exercise, could be even study habits, any habit you want to change. Like my goal this year is to reduce the amount of coffee I drink, which I think is impossible to do, but it's something I want to change. So if I want to make a change, I personally have to use this 5 A's approach. You have to remember: ask, advise, assess, assist, arrange. So let's start with the first one: ask. Now, when you're dealing with sensitive situations, you have to be careful. Would you go to a patient and say, "Do you smoke? How many cigarettes do you smoke?" And they're going to say to you, like, "Do I look like a smoker?" These types of things have happened to me, and I'm just like, "Oh my God, I didn't mean it like that." So how would you ask? How would you ask me if I smoke? What would you say to me? Any ideas? Because remember, even though it's a written exam, communication is tested. So I need to know. How would you guys ask me? Did you like smoking? What else? How would you ask me? I may get offended if you say that to me. I'll say, "Do I look like I like smoking?" What would you say? How's your smoking status? Tell me about your lifestyle. Okay. Yeah. So what, and it's so tricky, right? Because everybody is different. One thing I would say is smoking and alcohol can affect your medications and your medical conditions. So if you can tell me a little about your smoking status. So something like that. Okay, like this is the reason. It can affect your health. It can affect your medications. So tell me a little bit about your smoking status. Something like that. When you say the reason first, it kind of tones it down a little bit. But very good comments. Exactly. So that's first you ask. Say, okay, are they even doing it? Advise. What does advise mean? What is advise? Any ideas? Advice could be explaining to them, right? Why is it important to quit? But not just for the common reasons, but for their personal reasons. Personal reasons, okay? Personal reasons and personal motivators. Always remember this. People are motivated by their own personal reasons rather than those reasons that others may impose on them. Something that is important to you may not be important to the next person, but may also be important to me. So finding personal motivators are extremely important. Like I told you with the grandfather and the granddaughter. Since you recently had a heart attack, it's not good for your health. Exactly, because they just had a heart attack. So that could be a motivator. Very, very good. So you have to link these things together. And then we have to assess the patient. So assess is a big one. You're looking at what are their current medical conditions? Do they have any allergies? What are their preferences for drug therapy? Right? So maybe, and we'll talk about preferences, we'll talk about nicotine replacement therapy, bupropion, and varenicline. Today it'll be a faster demo, but in class we'll go into it in a lot more detail. But we have to try to figure out what treatment do we give the patient. then we have to assist, right? Guide them through the treatment, help them, whether follow-ups in person, by phone. And a lot of times in the beginning, we're doing more frequent follow-up, and then later on, it's less frequent. And then arrange follow-up, arrange any support they need. What if they need support groups help, okay? Or support from the community. There's also a condensed model, ask, advise, and act. So both are very important. But the main one is the 5 A's, which we just touched on. And give them the pamphlet. Exactly. Give them the information. Very good. Okay. Moving on to non-drug interventions. So you're going to see a lot of different versions of how pharmacists and medical professionals deal with smoking cessation. Some people will say, okay, well, if you only smoke, not only, but only 5 cigarettes per day, you don't need drug therapy. You can go to non-drug therapy. But some patients will say, well, Farah, 5 is a lot for me, and I want drug therapy. But you'll see a lot of evidence will say lower amount of cigarettes, you don't need it. And we'll talk about that more later. But anyways, different non-drug interventions are available out there. But when it comes to things like therapy, it may not necessarily be covered for the patient and can get expensive. Also, non-drug interventions can take longer, right? Because there's a lot of homework involved. When you go for counseling, they will give homework as well, okay, where you have to try to practice certain things. So for example, if you're trying to quit smoking, and let's say going out with your friends is a trigger. So they may give you homework associated with going out with your friends and changing your response to feeling like having a cigarette. So they'll give you a lot of homework and it can take longer. Some patients will say, you know what, Farah, I don't want to wait that long. Or some patients will say, I want to do it with drug therapy. As pharmacists, we are not trained heavily on non-drug therapy other than being a touch point in the sense of providing support and saying there's a neighboring psychiatrist, a neighboring counseling area you can go to, or a treatment center nearby, so we can guide them. Does non-drug therapy make sense? What I'm saying, does that make sense? Yes. Okay, very, very good. Okay, and if you don't understand or if you're not sure, just tell me no. You know, saying no is actually my favorite thing. I was in the pharmacy the other day, and then there was, I can't remember what it was. It was like some new drug I have never heard of. And we got a prescription for it. And the assistant comes to me. She's like, do you know what this is? And I'm like, no. And then she's like, aren't you a pharmacist? And I'm like, so? Nobody knows everything, right? So the more you admit you don't know, the better it is for you to learn. So make sure if you don't know, you tell me so I elaborate. And for everybody, okay? All right. Drug therapy. There are 3 main drug treatment options you have to be aware of for your exam. Nicotine replacement therapy, which I'll refer to as NRT, is the first one. And then the second one is varenicline. That's the second one. The third is bupropion. NRT is over the counter, so you do not need a prescription. Varenicline, you need a prescription. Bupropion, you need a prescription. And the prescription for varenicline and bupropion can be written by the pharmacist. Now, let me ask you guys this. If a patient comes to you and says, give me the best drug therapy for smoking cessation, I want the first line best treatment. Out of all 3, is there one that you would pick or no? What do you think? Is there one that's the best? Or are they all equal in terms of effectiveness? What do you think? And if you don't know, say you don't know. Equal, okay. Depends on the patient demographic. Let's say the patient has no comorbidities, no issues, no preferences. They just want the most effective drug. Let's say they have nothing, no issues with patient factors or anything. What would you say? What would it be? I'll wait a couple more seconds. So in fact, they are all equally effective. They are all equally effective based on the evidence. So there's a misconception that you have to start with the over-the-counter product before you go to prescription. But in this case, the guidelines and the evidence shows they're all equally effective, and you can start with either one of the three. Why is NRT placed behind the counter in most pharmacies? That's such a good question. It could be because of theft and stealing. So it could be a comfort level thing. So it depends on the owner, but generally it is over the counter and patients can purchase it on their own. So now that you know all three are equally effective, why don't we talk a little bit about the differences? Actually, before we do that, I want to touch on second line options. You don't have to know details about second line, okay? All I want you to know is what are the names of the drugs that are second line. So for example, clonidine and nortriptyline are the second line options, and that's all you need to know. That's it. We do not prescribe them. Well, we do not have the right to prescribe them in Ontario specifically, but doesn't matter. Just know the names. And then you have to know that all of like vaping, the electronic cigarettes, all of these things are not recommended. They're not regulated by Health Canada and can cause lung injury. So bottom line, all e-cigarettes, all of that stuff are not recommended. Okay. Now, let's talk about nicotine replacement therapy to start. Okay, so nicotine replacement therapy, as mentioned, is available without prescription. So let me just write that. So NRT is OTC. We have many different types of nicotine replacement therapy. You will have short acting. So short acting is things like your gum, lozenges, and we'll touch on this stuff way more in the class. Right now, we're just going to go very, very high level. Very, very good. Lozenges. Lozenges. They have these little inhalers. And then we have our long acting, which is your patch. So the patch is the only long acting product. Now, gums and patches and lozenges, all of it can be used together. You do not have to use them separately. The patch, though, you have to be careful, especially in things like pregnancy, because you don't want to be using these long-acting agents in pregnancy. You always want to go to short-acting. Another tip I will tell you, because a lot of people will ask me, if a patient doesn't want to use a patch, they're like, I don't like applying a patch. It's itchy. I don't want anything on my body. And they only want to use short-acting. How would you give it to them? And I'll tell you the trick. This is going to help you down the line. So 1 cigarette is equal to 1 milligram of nicotine replacement therapy. 1 cigarette is equal to 1 milligram of nicotine replacement therapy. So if you're using an inhaler, for example, 1 puff would be 1 milligram, or like 1 full inhalation, it could be, for example. And anyways, you don't have to know the details. We won't go over it right now. But studies show that usually patients need more than this and more than the recommended amounts, because everybody's bodies are different. But you're better off starting low and go slow. So this is the ballpark you will start with. So let's say a patient smokes 5 cigarettes a day and they want to use drug therapy. You can say, tomorrow smoke 4 cigarettes, and instead of your 5th cigarette, have a gum. And I know that some products only come in 2 and 4 milligrams, so that's fine as well. You could essentially use a piece of gum instead of a cigarette. Does that make sense? It's a little bit of a trick. So when you're on your exam and you're trying to calculate in your mind, at least this will give you a point of reference. If a person was using 7 cigarettes, they can use 7 to 8 lozenges or gum. Exactly. And some of them don't come in 1 milligrams, they come in 2, but at least you get an idea there. Okay, good. And now what about the patch? So what we're going to do is we're going to do the rule of 7, which I'm going to show you. You have to know the dosing of the patch on your exam. So let's draw a bit of a table here. Okay, and I'll show you. Okay, so from the left-hand side, the patient smokes less than 10 cigarettes per day. Okay, and the second column, I'll write it down and then I'll be able to explain it a lot easier. 10 to 19 cigarettes per day, then 20 to 29 cigarettes per day, 30 to 39 cigarettes per day, and then 40 plus cigarettes per day. So that's how much the patient smokes daily at the baseline. Okay, your patch comes in 7 milligrams, 14 milligrams, and then 21 milligrams. So it comes in multiples of 7. So again, your patch is available in 7, 14, and 21 milligrams. If the patient smokes less than 10 cigarettes per day, we will start with a 7 milligram patch. Then we do the rule of 7 plus 7. If they smoke 10 to 19, then we do 14 milligram. Plus 7, 21 milligram. Now, because it doesn't come in more than 21 milligrams, in this case, we would still do the rule of plus 7, but we would do it as 21 plus 7, so 28 milligrams. And then this is unlikely to come up on your exam. It's FYI. At this point, there's going to be a lot more support required. Does this make sense? So this is how much of the patch. Write that better for you. Does that make sense? The rule of 7. So less than 10 cigarettes a day, 10 to 19, 20 to 29, 30 to 39. Use your rule of 7 because the patch comes in 7, 7, 7, 7s. So 7, 14, 21, 28. Boom, you've memorized the dosing. Trick. One more thing though. What if this patient smokes within 30 minutes of waking up in the morning? So let's write that. Smokes within 30 minutes of waking. Add 7. Very good. Add 7. And at any point in time, the patient can use short-acting. So they can combine any short-acting when they feel cravings during this treatment. Does this make sense? Take a minute to process it. Does it make sense? Yay! So now do you think you can remember this after today? Less than 10 cigarettes, 10 to 19, 20 to 29, 30 to 39, 40 plus. Rule of 7 from the beginning, starting with 7 plus 7, 7, 7, 7. That's it. Now, what about the application part about this? How does it work? So let's say your patient smokes 30 cigarettes, okay? 30 cigarettes. So we need 28 milligrams, okay? So we'll do 2 patches, 21 and 7, one side by side. The first thing I usually ask the patient is, what is your quit date? In this case, let's say we pick tomorrow as the quit date. So from tomorrow, the patient will not smoke any cigarettes. They will put on the patch first thing in the morning. So tomorrow's their quit day, they put on the patch. And they can use short-acting nicotine replacement therapy as needed. Now, the problem with this is, okay, how are you going to go from 30 cigarettes to none and using the patch? Yeah, sure, your body may feel relief with the cravings because of the nicotine therapy, but what about the habits? The hand-to-mouth ratio. Patients always say, it's like drinking tea or snacking. Patients struggle, it's difficult. Even if you're going to get the cravings dealt with, it's the habit is also difficult. That's why I don't like this method, but this is the common method with the patch specifically. So you pick a quit day. On that quit day, you don't smoke, put on the patch, and then you can use short acting as needed. That's one way. And then the other way that I was saying is, instead of one cigarette, you can replace the one cigarette with one short-acting dose. So some people prefer it that way. What if your patient smokes and they slip up and they smoke on the nicotine replacement therapy? What do you think? They're on the patch, they're using short-acting, but they have cravings and they take a cigarette. It's okay? Okay. So technically, it's okay. Here and there slipping up is okay. Okay. And it depends. It may cause a patient's nicotine levels in their body to go really high, that it causes like jittering, but it's technically okay. It's not like absolutely contraindicated. They may actually feel better because maybe they felt like they weren't getting enough, or they also may feel extremely, extremely jittery. Okay. Now that's nicotine replacement therapy. Let's talk about briefly varenicline and bupropion, the two prescription ones. So remember, we said that all three are first line, but now other than NRT, which is OTC, let's talk about varenicline. So varenicline works on the same receptors as the cigarettes do in the body. And you don't have to know the receptors because this is not evaluating, this is MCQ, but it's the alpha-4 beta-2 acetylcholine receptors or nicotinic receptors. That's what varenicline works on, and that's what the cigarettes work on. So this is a partial agonist of the same receptor. The main problem with varenicline is the vivid dreams. It can cause significantly vivid dreams that keep patients up, or they will sleepwalk, or they'll wake up sweating and say, was this a dream or did this actually happen? But it is very, very effective. In fact, some studies showed that there was a slight benefit to varenicline over NRT and bupropion, slight. But because there isn't enough evidence, it's still considered equal. So I usually tell patients there's a chance of vivid dreams. Do you want to try the drug? A lot of patients I've seen discontinue it. They say it works so well, but I cannot wake up sweating, being confused if what I'm dreaming is reality. And I'm like, that's fair. It can also cause nausea. And then we have bupropion. Bupropion is first line for major depressive disorder, but it can also, a different version can also be used for smoking cessation. So this one increases the norepinephrine and dopamine in the body because cigarettes also release dopamine, causing the feel-good effect, and that's what bupropion does. Bupropion can cause severe nausea, dry mouth, and insomnia. So it can keep people up at night. So you don't want to take it too close to bedtime. Again, we'll elaborate more in class. Today I'm going at a bit of a faster pace, but it will keep people up at night. Bupropion for smoking cessation is dosed twice a day. So it's dosed morning and late in the afternoon. But bupropion increases the seizure threshold. seizure is increased, which means that the patient's risk of seizures goes up with bupropion. So if somebody has a history of seizures, they cannot, it is absolutely contraindicated to use bupropion. Also, anybody using bupropion should separate the twice-a-day doses by at least 8 hours. Because of the seizure risk, the twice-a-day dosing has to be separated by 8 hours. Okay, so those are the main key points about the 3. I want to address the great question online. Can varenicline be used in patients with controlled hypertension? Let me ask you guys this, and a lot of patients ask me questions. Can nicotine replacement therapy, can varenicline, can bupropion used in patients with high blood pressure? Does smoking increase blood pressure? Do cigarettes increase blood pressure? Oh, yes, decrease the seizure threshold. Increase, yes, absolutely. Increase the risk of seizures, decrease the seizure threshold, and increase the risk of seizures. Seizure risk. So the seizure threat, let me make sure I clarify that here. So increased seizure risk, decreased seizure. There you go. Now that's totally clear. Thank you. Thank you, thank you. So does smoking cigarettes increase blood pressure? Yes. So even if nicotine replacement therapy can increase blood pressure, for example, isn't it still better to use NRT versus cigarettes in somebody with high blood pressure? What do you guys think? So if you have a patient with high blood pressure, I know if you read the product monograph, it'll say all these things about cardiac risk and this and that. But if you're going to compare cigarettes to drug therapy, exactly, the drug therapy is still better. When I worked in the cardiology ward, when a patient had a heart attack, they couldn't go outside for a smoke. They were hooked up to IVs. So we would give them the patch right away, right away. Okay. But exactly, I mean, if you have another option, like you can give the patient varenicline instead. If they have high blood pressure, you can give them varenicline instead because of patient factors, right? Because nicotine replacement therapy is the one that increases blood pressure. But what I'm trying to say is that if a patient wants nicotine replacement therapy and they have high blood pressure, it's okay, because it's still better than smoking cigarettes. And that's where all the patient factors come into play. Okay. Also, what would be the quit date for patients using varenicline or bupropion? Is it like nicotine replacement therapy, like the patch, where it's the next day? What is it? 2 weeks? So it's interesting because it's actually, write it higher up, 8 to 35 days roughly. So what does that mean? I can start varenicline today and I can keep smoking for another 8 to 35 days. And as the varenicline builds up in my body, my desire to smoke will be less. So you slowly taper. Okay, exactly. So it's a little bit different. And so in reality, some patients still end up smoking a cigarette here or there. On your exam, it would be very, very high level. There's so many hypotheticals we can get into, but these are the main points for your mind to focus on for your exam. Okay, so let's keep going. Very good, guys. What about pregnancy? When it comes to pregnancy, you don't want to use varenicline or bupropion. You can use short-acting nicotine replacement therapy. So you can use low doses of the gum. or you can use the lozenge, or you can use the little puffer. So as long as it's short acting, it's okay. We want to avoid the patch unless we absolutely need it. Breastfeeding, same thing, short-acting nicotine replacement therapy. There isn't enough data on varenicline or bupropion. When it comes to young patients, so the treatment for smoking cessation in terms of varenicline, bupropion, and NRT in less than 18 years of age has not been pushed for pharmacists. Like they say contraindicated or not recommended in under 18. But when you read the evidence, it says, but hold on, are cigarettes really better? Or if you're 16 or 30, what's so different? Why can't a 16-year-old use varenicline versus a 30-year-old? So the evidence and the literature says, even if these drug monographs say don't use it in less than 18, use it in less than 18. Use it because it's still better than smoking cigarettes. And then other special considerations, we talked about the cytochrome P450 enzymes. We talked about people with high blood pressure as well. Okay. Some patients prefer nicotine replacement therapy or bupropion, again, because of the vivid dreams. The vivid dreams can really, really affect drug therapy, but all are equally effective. Following up and providing encouragement, reassurance is very important. Within the first week, you want to follow up with them. Ideally, the next day initially, but within the first week, it's crucial, and constantly follow up and help them and accept that relapse may happen. Keep in mind, to answer the question online, nicotine replacement therapy and varenicline, nicotine replacement therapy and bupropion can be used together. So NRT plus either varenicline or bupropion can be used together, but that's out of the scope of your exam. But we do not use varenicline and bupropion together. We do not use varenicline and bupropion together, and you're most welcome. Okay. Now, this is a very brief algorithm that you can read at your time, but, and I'll go over it at high level. We start by asking the patient, how much do you smoke per day? You want to figure out when was their last cigarette. Was it months ago? Was it yesterday? What are they really looking for? Ideally, you would get the number of cigarettes per day from the patient, which would be likely the case on your exam. Then we want to try to educate them. Are they ready? If they are ready, let's try to make a plan for them. If they're not ready, offer education, offer support, and say, you know what, when you're ready, you can come back. Now, this is where I want to touch on the number of cigarettes. A lot of people will say if the patient smokes 10 or less cigarettes per day, we don't necessarily have to start with drug therapy. So that is up to the patient. This is not something that's set in stone. Most people who smoke 10 or less will still require drug therapy, but they may be open to non-drug measures. So bottom line, every patient is eligible for drug therapy unless they would like to start with non-drug therapy. Okay. Does this make sense? You will also see that it says varenicline can be prescribed first, and that is based on that little evidence I told you that says consider it first because of it may be a little better. But all three are first-line treatments. All three are first-line treatments. So you have to really assess what does the patient really want first. Okay. Does that make sense? You don't have to know combination therapy at all. You don't have to know second-line treatment. I just wanted you guys to see, based on therapeutic choices, what is the process. Does that make sense? In case of myocardial infarction, what do we prefer? Either varenicline or bupropion can be used. You have to look at the patient's other comorbidities. And even nicotine replacement therapy can also be used. Does this make sense? How do you guys feel? Makes sense? Any concerns or questions? We'll wait a couple seconds, then we'll do a quick quiz. Oh, thank you. Well, it's because you guys are so great. You make it fun for me. Does that make sense? Awesome. So a quiz about a question: if patient has seizures, what to recommend? Very good. You can use varenicline or nicotine replacement therapy. It's only bupropion that you cannot use. Okay? Only bupropion that you cannot use. You're welcome. What is the best choice for patient with schizophrenia, please? It depends on what other drugs they are using. Depends. But they could probably do varenicline or nicotine replacement therapy. And depending on what other dopaminergic medications they may be using, we could consider bupropion, but that is very complicated for MCQ. You're so smart, you're just thinking of 2 ahead. That's beyond your exam. Okay, you're thinking of very complex, but it's a very good question. In eating disorders, bupropion can be used with caution or completely contraindicated. Very good. We'll be talking more about this in class, but essentially, eating disorders can cause electrolyte disturbances, right? Because if people, for example, have bulimia, they'll be throwing up what they eat. So their potassium, magnesium can be out of sync. And because of having potential electrolyte disturbances, they have an increased risk of seizures. So it's not contraindicated, like bupropion's not contraindicated. It should be used with precaution. Another tip for you guys: when something is contraindicated, that means like you cannot use it. There are very few contraindicated situations out there, like real contraindications. Mostly situations have precaution. Use it with caution, but not true contraindications. Having a history of seizures is a true contraindication to bupropion, but having any electrolyte disturbances or having bulimia or anorexia is a precaution. Okay, what if the patient is already on extended release bupropion for depression? Can he or she use bupropion in the other formulation to target both depression and smoking cessation? That's a good question. So we would not use both. You only use one kind of bupropion. And usually I'll tell the patient, do you want to use the bupropion for smoking cessation or depression? Which one do you want to use? Which one do you want to prioritize? It'll likely work for both, but I usually let them choose. They only need to use one of them, not. Very good questions. You're most welcome, dear. You're most welcome. But this is the level on your exam. And so when you're hearing me talk about the concepts and you know how I'm trying to rationalize and explain, that's how you have to approach it. And you know what I was telling another student the other day was, close your eyes and just listen so that you can grasp the concepts. So I want you to be able to walk out and say, I understand. Okay? Dr. Permeet, is it possible to launch the quiz?